everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hello, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, I had the privilege of speaking with two titans in the field of cardiac imaging, Dr. Carlos Collet and Dr. Jonathon Leipsic. Dr. Collet is an interventional cardiologist practicing in Belgium, and Dr. Leipsic is a radiologist in Vancouver, Canada. Both of these gentlemen are world-renowned for their pioneering and prolific work in advancing our understanding of imaging and characterizing coronary plaque biology and physiology. Dr. Collet and Dr. Leipsic are the senior authors of a recently published review in the journal titled as follows: Coronary CT Angiography to Guide Percutaneous Coronary Intervention. This review covers a broad range of topics, including coronary CT for complex native disease, FFR CT, bypass anatomy, aneurysms, fistulas, and chronic total occlusions. Without further ado, let's jump into my conversation with Dr. Collet and Dr. Leipsic now. Welcome back, listeners. I am now privileged to be joined by the senior authors of our featured paper, Dr. Carlos Collet and Dr. Jonathon Leipsic. Thank you both for joining us on today's episode.
Pleasure to be here.
Thank you for having us.
Of course. Now, before we begin, why don't we begin by learning a little bit about you both? Could you tell us where you both are from, where you are currently, and what your current academic areas of interest are?
Thank you, Praveen, for the opportunity. Look forward to this discussion. So as many on this podcast may know, I do imaging. I have a focus in cardiac CT in particular. I practice medicine in Vancouver and have spent the last 15 years really trying to understand how CT can support the diagnosis of patients with suspected but not yet confirmed coronary disease, understanding mechanisms of risk and prognosis and atherosclerosis, and then ultimately physiology. But what I'm really excited about and why I'm really grateful that Carlos would find the time to join this conversation is that, you know, some of my original research was in CT to support structural heart disease interventions. And we've seen how that's really matured with the field of structural heart disease interventions. And on the other hand, coronary angiography and intervention predates the integration of CT. And so I'm really excited to see and have learned beside and with Carlos as it relates to his vision and the vision of others around how to really integrate CT into this mature field, but to continue to improve it. So I'm excited for this conversation and to continue to learn from Carlos.
Excellent. Thank you, Jonathon. And how about you, Carlos?
Well, thank you, Jonathan, for that kind words. So I'm an interventional cardiologist. I practice in Belgium in the Cardiovascular Center ALS. So my practice is pretty focused on coronary artery disease. And I started the journey of CT 15 years ago. As soon as I finished my interventional training, I had a good advice from one of my mentors to train in CT. So I went to the US and by the time I trained myself in CT and went back to practice. And everything just from that moment came together. And I started seeing how these two worlds actually complement each other. And yeah, this has been a journey for almost 15, 20 years now. And we're really happy to be pushing actually the boundaries of coronary CT now inside the cath lab, which I think is the topic of today.
Excellent. Well, Carlos, thank you. Thank you both again for joining on the podcast. I think this will make for a very nice multidisciplinary conversation in this topic. Let's begin by talking about the review itself. Your review is focused on coronary CTA as an adjunctive to planning invasive angiography in a variety of different pathologies. Carlos, maybe you can speak to this. I know there are many interventionists out there that decry interventional angiography in itself is imaging. What is the need for more imaging before or after I'm in the cath lab? How would you respond to this?
Well, that's a very nice question. And the answer is pretty simple. Conventional angiography is an excellent tool to look at the lumen, to know what is happening inside the vessel, to know if there is an obstruction. But unfortunately, the plain angiography doesn't tell you anything about the plaque that you are treating. So sometimes we embark in these interventions without really knowing what is behind it. And that makes a huge difference, not only for the technique, for the vessel preparation, what to expect, from where to where we have to treat, what is the type of pathology that we're treating. So for so many years, we have been actually blinded to this information by only looking at the conventional angiography. And now that, well, at least in a few centers around the world, CT is part of the diagnostic workup of these patients. And now us interventional cardiologists have learned how to read these exams. Then we go now into the cath lab pretty well informed about the type of lesion that we're treating, even before we even make the first injection. I always like to say that the interventional cardiologists are pretty unique in the sense that we are one of the only surgical specialties that actually go inside a case without knowing anything of what we're going to find. And on top of that, we have to take a decision that is about the treatment of a coronary artery in about 10 to 20 seconds. So this is something actually that, in my view, will change the field because it just gives us so much information before we start the procedure. And we feel that the level of certainty of what we're doing is increased just by having a good understanding of the pathology that we're treating.
Well said, Carlos. And to that point, Jonathon, from the perspective of radiology, how do you approach those conversations with your interventionists that may be doubtful of the supplementary value that coronary CTA brings to the table?
I think it's really important. I think that the transition from scientific thought development, which has really been led by Carlos and his colleague Jeroen Song, Professor De Bruyne, and others, Nico Piazza, who's really, as an interventionalist, really focused on using CT. I think we're going to see generational shift, right? The people that are training and are really, as part of their core training, are exposed to cardiac CT. I think it will be just part of the evaluation of the patient and understanding their anatomy prior to the procedure. I think those that have been doing it for 20 to 25 years, it's a bigger struggle, no doubt, right? I mean, the barrier to entry is greater. But I think that the real shift with the AHA-ACC guidelines, the reason I think it will have a pivotal impact is it's no longer about the interventionalist ordering the CT, trying to suggest that, she should order the CT before she does a cath, after the referral has already happened at the cath. But I think now that there'll be increased penetration of CT, now it's just a matter of the interventionalist sort of learning how to become facile with the technology, understanding what data can be provided. And it's free information, right? So I think when it's there, once the interventionalists really appreciate that, I really do believe that they will pursue that information because, as Carlos mentions, their task at hand right now is almost impossible. And I mean, they're managing such a complex disease process as coronary disease, and they're doing it without even knowing whether the patients have coronary disease, and then making ad hoc decisions. And that leads to far too many patients being incompletely revascularized. So I think that the clinical drive will be there, and the continued manifestation of the science from people like Carlos will continue to, I think, push the field.
Perfect. I think that leads nicely into what is opened in the discussion in your review, which is a description of coronary lesion characterization by CT and how it complements what can be done in the cath lab. Some of the imaging features that are mentioned are some of the things we see every day on our coronary CTs: lesion length, bifurcations, really intense severe calcifications, non-calcified plaque, and the so-called high-risk plaque features. For some of the novice imagers, this is probably a tremendous amount of information to not only analyze, but also include in a report to package to whomever the referent is. In an effort to optimize some of the reports for our referents, do you have suggestions for our imagers out there for how to streamline their search pattern and therefore their reporting for our referents?
Well, I think from the interventional perspective, one of the things that we have learned about CT is that actually the length of the lesion, which is a very simple parameter to obtain, is actually, in my view, CT is the gold standard to assess the lesion length. Why? Because it doesn't only give you the lesion in the three-dimensional space, but also avoids all these mistakes that we do sometimes in the cath lab because the image is a little bit foreshortened, and then you don't see actually the complete length of the lesion. So this is something that is very important for us. And when I'm speaking about length of the lesion, I'm thinking about the extension of atherosclerosis. Sometimes we see that the stenosis can be rather short, but when we look at the CT, we see that the plaque actually extends proximal and distal to that stenosis. So actually implanting a stent that could be shorter than the disease itself could lead to complications inside the cath lab, like dissections that require additional stenting and so forth. So this is a very easy way to get better information that is similar to the one that can be derived from intravascular imaging, but of course in the non-invasive setting. The second, if I have to prioritize two, is the distribution of calcium. Calcium is the biggest enemy of the interventional cardiologist. We struggle with this every day, and actually knowing what is the type of calcium that we're treating help us selecting the tools that we do have in order to avoid complications, and most importantly, to avoid a stent under expansion. When we put a stent in the coronary and it doesn't expand well because of the calcium, that is an independent predictor of restenosis and thrombosis. So this is something that we have to avoid. And coming back to your previous point, conventional angiography doesn't tell you anything about the calcium. So these are two tools that, in my view, complement each other pretty well to avoid common problems during a PCI.
Excellent. And you had mentioned in this response some intracoronary imaging separate from coronary CTA, for example, IVUS or OCT. There might be interventionists out there that would claim that IVUS and OCT can provide all of this information for us quite robustly. Is there a reason then to perform the CTA separate from intracoronary imaging? And if so, why? Also, how robust is coronary CTA relative to some of these intracoronary imaging studies?
I'm a believer in imaging in general, but I'm also a user of OCT and IVUS, and I like to use both of them. And I have to say that the information that you get from IVUS and OCT, they're a little bit different from each other, but there is actually all the information that you need to look at the plaque composition, plan extension, etc. Why do we think that CT is so important? When you look at the data from the American Registry of PCI, you see that the use of IVUS is 2.8% of all PCIs performed in the US. OCT, 0.8% of the PCIs done in the US. This means that more than 95% of all the patients that are being treated is done without actually knowing what is the composition of the plaque. So CT comes as another tool to help us in the pre-procedural planning. So I have the impression, and I want to hear Jonathon's opinion on this, that the field of CT has evolved so tremendously, not only with the hardware, but also with the post-processing software that we have today, into a moment that when I see a CT, I can truly plan my procedure. And sometimes I don't see a need to perform additional intravascular imaging before PCI to understand the distribution of the plaque and the plaque composition.
I think those are such important points. And, I think, Praveen, as has been highlighted, there's the challenges with regards to the technical feasibility, the cost, the morbidity and risk, invasive intravascular imaging, and even intravascular physiology is obviously incredibly robust, but it doesn't come without risk, especially in people with lesser experience. So I think, really augmenting that decision-making and having a reasonable understanding, I think it can even refine your decision as to when you need intravascular imaging instead of going in without knowledge. So I think there's real advantage to that upstream decision-making and discussion. And one thing we haven't highlighted, but I'd be curious to Carlos's thoughts. I've heard other interventionalists talk about the informed consent process and, understanding and being able to have that conversation with the patient. Not, I don't know if you even have coronary disease, but rather, there's a very high likelihood you have a lesion in the LAD that I'm going to want to treat, and this is what I'm hoping to do. And so I think those conversations are much richer, but obviously I would yield to Carlos since he's the one having them.
Jonathon, I think you have touched upon a very important point, and to be completely transparent with you, even in cases where we are thinking that the patient could be treated, let's say we're talking about the left main disease or three-vessel disease, we even talk to the patient before and say, listen, you have a disease that can be treated either with surgery or with PCI. Here are the risk and benefit of the two. And we are going already to diagnostic catheterization, where we're going to confirm the disease severity, but we are already having discussions in the heart team before the patient actually steps in the cath lab. And that, of course, streamlines the whole treatment pathway. And we make better informed decisions about what is the best for that specific patient.
There's so much to unpackage there, and what is apparently a paradigm shift in how we're approaching the pre-procedural evaluation for these patients. But before we dive any further into coronary lesion characterization, I wanted to touch on something you had just mentioned, Jonathon, with regards to intracoronary physiology. Within your review itself, you mentioned that inconsistent relationship between anatomy, both on invasive angiography or coronary CT, and the physiologic or hemodynamic consequence of a particular stenosis. That ends up being a nice segue into fractional flow reserve or intracoronary physiology, as well as FFRCT. FFRCT is way more rich than just saying it's positive or negative. So I wanted to take some time now to touch on some of those more advanced interpretations of FFR and FFRCT beyond just positive or negative.
You know, that's a great question, and thank you for that. I think that's one of the things that we're starting to learn. You know, when we integrated the technology originally, I really thought of it as a binary tool. But of course, we know from the invasive world that the depth of the physiology is a very strong prognosticator. But also, as we've seen from Carlos's nice work published in 2020 in JACC, where they looked at the mechanized pullback of invasive FFR and delineated different phenotypes of physiology, that this provided a roadmap for us to understand how the translesional pressure loss and the so-called delta, which we've seen as prognostic as it relates to perhaps helping us identify future culprits from the work from Quan Ku, but even beyond that, in refining our referral to the cath lab, especially in the gray zone. So, you know, if you have a value distal to a stenosis that's 0.6, you know, the translesional pressure loss is less relevant because, you know, by definition, it must be significant, right? Because it's so profoundly abnormal. But in that gray zone of 0.75 to 0.8 or even 0.71 to 0.8, understanding the phenotype, we feel is really something that is invaluable to adjudicate non-invasively to try to mimic some of the elegant work, as mentioned, that Carlos and Professor De Bruyne and others have manifested from the invasive world. So,
Jonathon, I think that from the invasive part, and this is kind of a parallel development with the CT and FFRCT and what we're doing with the invasive FFR measurement. So we are moving beyond the initial concept of FFR. FFR, we went with a pressure sensor, we put in the coronary, we induce hyperemia, and we get an idea on how significant was the disease in that vessel. And that is almost the complete literature until 2 or 3 years ago. Then we started actually, instead of measuring one value in each vessel, we're starting to map how was the pressure loss going down in that vessel. And what was the whole point of doing this exercise of understanding how focal or how diffuse was the coronary artery disease? And the whole problem or the whole issue relies on the fact that stents are a focal therapy. So implanting stents in diffuse disease actually makes little sense. We have now proved that implanting stents in diffuse disease, the patient actually doesn't improve from angina. They keep having what we call residual angina. There are a number of complications associated with PCI in cases with diffuse disease. So we have come to a point where we are able to differentiate, to segregate patients with significant coronary artery disease in two groups. One group that are patients with focal disease, and these patients clearly benefit from PCI. And we have the patients with diffuse disease that we believe that there are other treatment options, being medical therapy or surgery, that are more appropriate for that specific disease phenotype. And now, of course, we have now translated this into FFRCT, mainly because I like your word, Jonathon, is we have this pullback or this mapping of the pressure for free, because that's the beauty of the computational fluid dynamic model that gives you the possibility to analyze the pressure at each point of the coronary artery. And by doing this, we are doing exactly the same that we did with the invasive physiology now with the FFRCT model. And I have to tell you that I have some patients in my consultation that I see how is the phenotype of pressure loss, and they can have a 70, they can even have a lower value, but I don't see a benefit of doing PCI in that particular case because there is not a localized lesion, there is a diffuse pressure loss along the vessel. So this is a field that is moving forward pretty fast. I have the feeling that there is an advantage of FFRCT because we are in the planning phase, and that makes a lot of sense. You have time to think, and of course, not all the pathology is simple to handle. So I think this is giving us just such a lot of more information that I think we're going to do better treatments when this technology is available in clinical practice worldwide.
Carlos, Jonathon and I have had a previous discussion about serial stenoses and the impact of both invasive and FFRCT-based approaches to planning PCI and serial stenoses when clearly at least one of these lesions is hemodynamically significant. I'd like to get your thoughts on how you've seen the utility of coronary CT and FFRCT in planning your approach towards serial stenoses.
Well, serial stenosis is, I think we can have a complete podcast for serial stenosis. It's a passionate topic, but what I can tell you is that serial stenosis has been put in one box. And this is not true. Not all serial lesions are the same. And we have seen serial lesions that you see. Serial lesions is an angiographic definition, it's an anatomic definition. We have seen the serial lesions with completely diffuse pressure losses. We have seen serial lesions with one lesion being focal and the other one being diffuse in terms of pressure loss. And we have seen the typical pattern of the book of two serial lesions where each lesion actually contribute to a gradient. So I think this is the first element that we are learning from the invasive physiology and from FFRCT, that not all serial lesions are the same. And it has to be, of course, is related to the basic principles of fluid dynamics and how these behave in terms of pressure losses in different parts of the vessels. But having said that, I think that we have tried in the past a lot using invasive physiology to predict what would be the outcome of a particular PCI strategy, proximal first, distal first, or whatever the treatment strategy might be. And I have to say that all the mathematical models that have been created have failed to provide an accurate answer to the question of what lesion should I treat first or second. When we did the same exercise, and this was done by the group of Divaca Pereira together with the team of Harflow on using computational fluid dynamics to understand better the behavior of serial lesions after the removal of one of the lesions, we have seen that there is a huge potential actually of using CFD to understand the treatment of this particular complex subset of lesions. In other words, using this new tool, which we call the FFRCT planner, and we remove one lesion, we're able to better understand what is the consequence of different strategies, and of course, trying to minimize the number of stents, because we know that the more the stents we implant, the worse for the patient in the mid and long term. And of course, maximizing benefit in terms of higher flow at the end of the PCI, which is of course measured by the post-PCI fractional flow reserve.
Excellent. As you had mentioned, we certainly could have an entire podcast episode about just these very fascinating topics, but I do want to touch on some others that you mentioned in your review. Some of those involved in more complicated revascularizations are CABG characterization. Very frequently we'll get requests from our cardiology group where we see a patient in clinic who has had a CABG previously, but we do not have the operative records for it. We're happy to perform the coronary CT imaging, but beyond the number of grafts and the bypass hookup locations, I'm curious to know what additional information can be provided to our referents that'll really help enrich their approach to the patient and potentially what they'll do in the cath lab.
I think that's a good question, Praveen. I mean, one of the things I like, and actually just on Friday or Thursday, I was on the clinical schedule and we had a couple of them, and they're kind of like a bit of a surprise present. You never know what you're really going to get, right? I mean, sometimes it really doesn't add much and it's very clear anatomy, there's some proximal disease and you think, okay, well, that wasn't really very helpful. But then you get a couple of cases like we did the other day where the surgical anatomy was frankly wrong, where there was a suggestion that there was right coronary dominance and that they had grafted to the right PDA when it was clearly grafted to a left system. I think understanding obviously the caliber of the grafts, the location, the ostia, the course of the anatomy, ungrafted territories. One of the things that I think is very challenging, and I learned from Stefan Offenbach many, many years ago, is he said, in many ways, he's the pioneer of a lot of these things. How can CT help the interventionalist? He said, after a cath was one of the top reasons to do a CT. And I was thought, really? And the reason he mentioned this is sometimes it's hard to tell. Is it a chronic occlusion? Is it an absent vessel? Is there a missing vessel? What is the course of the vessel? Is that actually a diagonal and the LAD is occluded, and the patient's been ascribed to having Takatsubos, for example, but there's actually thrombotic occlusion of a vessel that you miss. So, he highlighted that the frequency that CT picks out such glaring misses or challenges with invasive angiography is obviously low. But when it does, it's no other test can do it. So I think it's the same for bypass, is that, a lot of the time it's modest, it's incremental value, but then there's a few cases where, it really disrupts your understanding of the patient's anatomy and risk.
So, Jonathon, from the technical perspective, I have to say that sometimes when you embark in these post-CABG patients and then you start changing catheters because you cannot find the bypass and you keep injecting the aorta because you cannot see the bypass, and then you are pretty sure that it's in the report, so you're trying to look for it. At least you have to see it included, but you cannot find it. This is not uncommon. So if you really know where the bypass is located, more or less what is the projection that you need, what is the height of the bypass relative to the aortic valve, that really save you time, save you contrast, and of course, contrast and radiation translate into procedural safety. So this is one of the scenarios that, in my view, in the next 5-10 years, all these patients will go first to CT and then come to the cath lab because it makes the procedure much, much faster and safer. The next point, and this, I have seen this a couple of times, is that you start looking for the bypass, you cannot find it, and then you take a decision that you have to treat the native vessel because you think that the bypass is occluded. Then you embark in a completely unnecessary PCI because you couldn't find the bypass before, and then you end up implanting a stent that was actually not necessary because the bypass was open and you couldn't find it. So there are so many things that happen in the cath lab in this particular subset of patients that are very sick, that comes after surgery, that I think having a good roadmap of the surgery, not only in terms of patency and location, but also in terms of the complete anatomy, as Jonathon mentioned, is extremely important.
Carlos, as you had mentioned there may be endeavors that are embarked upon with regards to chronically occluded vessels that are not planned for initially, either in bypass patients or those that have not been previously revascularized. Coronary CT does have an emerging role in planning these chronic total occlusion patients, and wanted to get both of y'all's perspective and what the potential utility can be beyond what has been described thus far in the invasive literature with regards to sump characterization, tortuosity, et cetera. Is there reasonable incremental data that we're getting from a coronary CT that helps in those rare cases in which we do attempt to intervene on a CTO?
Yeah, I mean, Carlos can speak to it, but there have been small randomized trials that have shown that. And then obviously the great work from Max Polsky and others looking to CT Rector and JCTO score. But, I think one of the things I learned from John Webb many, many years ago when I joined his team and started to show, tried to look at how CT could help him, was I started to realize that the barrier to entry, if the data is already acquired, is very, very modest, right? That's very different than saying to Carlos, okay, one or the other, we're going to randomize CT, no CT, or, you have to show heart event reduction, these sorts of things. I think when the CT is done as part of this diagnostic paradigm, right? You do the CT because you want to know if they have coronary disease in a patient with symptoms. And then the data is there. Then, it's just about leveraging the data, and the barrier to entry is much more modest because it's just being explored. It's not CT versus no CT. and mortality reduction at a year, obviously. But it's a lot of the factors that Carlos highlighted. One of the ones I'd love Carlos's thought on is the referral to the right CTO operator. One thing that we don't look at is, if you have a very complex anatomy, it doesn't mean that it can't be recanalized, but maybe, you start, altering the referral to a person with more experience and a CTO operator and so on. So I think these are the opportunities with the CT data already existing.
Yeah, I think the CTOs is an evolving topic, and we have seen in the last 5 years a boom in CTOs, in interventional cardiology. We have seen that it looks like a separate subspecialty in interventional cardiology. We have the people that only do CTOs. And I have to say that the amount of material, the new material that they have and new techniques and so has made the success rate of CTO coming from 60, 70% to almost 90% today. So I do agree with Jonathon that CT, and I use it in that specific way, to know to whom I have to send the patient. If it's a short CTO, Jonathon, I put it in my program. If it's a long CTO that has to be retrograde, I think it's best done by a dedicated CTO operator. So the people that have the knowledge. And I think this is the way we are now today using a CT in my cath lab for CTO planning.
More generally, Carlos and Jonathon as well, what other ways have you seen pre-procedural CT change the referrals that you're making to, say, your surgeons, your complex interventionists, et cetera, or even potentially to our structural team for other incidentally identified structural lesions?
Well, I can tell you that in my practice, the surgeon are the ones that are benefiting a lot from CT and FFR CT. And the main reason is that sometimes we think that the disease is focal, but having the CT beforehand, having an FFR CT with a diffuse pressure gradient, and understanding that PCI is not the best option for that patient is shifting quite some patients from what would be a PCI to a surgical procedure. And now we're doing quite a lot of this mid-caps or robotic limas, which are quite a nice thing to have because it's a long-term patency with a relatively small surgery. So this is the way that we have seen that the CT has impacted us as interventional cardiologists. And of course, this comes with a shift in the minds of the interventional cardiologists on accepting that we cannot treat diffuse coronary artery disease. And this has actually a big impact in my practice in the last few years.
I think for me, Praveen, what I would say is, we've seen a lot of pushback post-ischemia trial, people conflating the data from ischemia trial. And it's often the case that sort of buzz around trials to sort of lead to overreach, right? Obviously, I'm not casting aspersions to the trial, that although I know Carlos and I have mutual friends at Maine. That, it's a large randomized trial, obviously a much bigger and more impactful trial than I would ever hope to contribute. That being said, some people, and I hear trainees come through saying, revascularization it doesn't make a difference aside from angina relief, which is clearly not what the ischemia trial shows us, right? I mean, obviously it was a modest number of patients included. There was a lot of crossover, 30% of patients, 35% crossed over. But most importantly, revascularization reduced spontaneous MI, and spontaneous MI was the only MI associated with mortality, even at not a long term. Imagine if we actually had granular good data out to 10 years. And so I think what this whole discussion really, and my work with Carlos and people like Carlos over the last number of years has really, it's been inspirational to understand that the role of imaging could be not just in the diagnosis, but continuing to enrich that selection. Which lesions, which patients, who's really going to derive benefit? And imagine that if you look at the meta-analyses to date, that Carlos and his friends have been able to reduce spontaneous MI and a clear signal for improvement in outcomes going to the cath lab without any knowledge and any information. And then making often ad hoc selection of which lesions to PCI. So I really do think the future is so rich because it's already PCI has a profound impact. And then if you add, invasive imaging, invasive physiology, but upstream imaging, I think those referrals and that guidance becomes much, much greater. And I think we're going to see a significant improvement for care for our patients.
Excellent. And with regards to the future, what specific ideas that we haven't already mentioned are y'all most excited for in CTA, PCI, and coronary disease altogether? Jonathon, why don't you take this one first?
Sure. I really think this is the final frontier of CTA, is going into the cath lab. And, Carlos and your own song and the team have some very elegant work from the P3 trial, which will hopefully be published soon, and are also embarking on prospective trials, which I think will be really important. I think that really understanding and titrating treatment beyond overly nihilistic approach of saying, oh, just medicine and see how people go, which I think is not how I would want to be treated, versus, PCI of every lesion. So I think that, and then continuing to advance our understanding of the response of atherosclerosis to medical therapy, plaque stabilization, and understanding also if we can integrate plaque morphology and hemodynamics into understanding precursors of MI. But I really do think this area is one of the most exciting for the field of cardiac CT, really penetrating into the cath lab and engaging with our interventional colleagues.
Completely agree. Carlos, what are you most excited for?
Well, I think I have to agree with Jonathon that the integration of the CT and the cath lab is a natural step for the technology, and it's so powerful to have these models in front of you while you're doing your procedure, because it reduces a lot the uncertainty in decisions that look pretty simple, but can have a profound impact on the patient. For example, device selection, type of vessel preparation, etc. So I think this is a game changer from the perspective of the interventionalist, and I think it's going to be welcomed by the community once we have this live image of the plaque inside the cath lab. The second point that I think is going to change in the future is that we have seen CT, and particularly FFRCT, as some sort of gatekeeper of the cath lab and to reduce unnecessary referrals to the lab. But I think this is going to be even extending to the decision of whether PCI would be a beneficial therapy or not, beyond the assessment of lesion significance. And I think this is going to be in the hands of the imagers who knows quite a lot about coronary artery disease to start saying, okay, you have significant coronary artery disease, but there is little benefit expected from that type of procedure. And then this concept of gatekeeping will be expanded with a deeper understanding of the effects of each of the therapies that we have available today for that particular pathology.
Wow. Yeah, I totally agree. This discussion thus far has been absolutely wonderful. We've touched on a whole bunch of different topics, and I'm sure there's plenty more that we would like to discuss, but are there any final thoughts that you guys would like to contribute before we conclude?
Gratitude. Thank you for the opportunity. It was fun. It's always great to hear Carlos's thoughts, and Praveen, I think this is be very curious to the feedback. It's an exciting topic, and it's great to get it out to the imagers out there.
Well, thank you. The same. Thank you for the invitation. It's wonderful to chat. These are, again, very relevant topics. And I think we are just in the middle of a transition, of a breakthrough in the field. And I think this is going to be quite an exciting field for the next couple of years, John.
Jonathon and Carlos, thank you both so much for joining us on the podcast, providing your time and expertise. We really, really, really appreciate it. Thank you again.
Pleasure.
Thank you.
And to our listeners out there, thank you all for tuning in and listening to the podcast. If you like what you hear from us on the Radiology Cardiothoracic Imaging podcast, please rate, review, and subscribe to us on whatever platform you listen to us on. We will see you next time.